Welcome to the inaugural episode of Drug School. My name is Adam, and of course, I'll be your instructor as we go through learning about pharmacy. Today, we're going to talk about pharmacy pricing, and pharmacy pricing is basically where everything is made up and the numbers don't matter. I say that jokingly because they ultimately matter in how much money comes out of your pocketbook when you walk into a pharmacy, or how much money you take in at the register if you work in one. But we're going to talk about the very convoluted way prescription drugs are priced in the United States, and it is a very wild and crazy system. So, why are drugs so expensive? This, when I was in retail practice, was probably the most frequent question I got asked whenever I was helping out a patient. And part of that is there's no transparency in this entire system. We're going to learn why in a minute because the crazy systems that we use to calculate prices vary greatly from one insurance company to another. It's probably the only industry where I can buy a bottle of something to retail or for retail use, meaning I can go buy a bottle of fluoxetine, and until I adjudicate claims against that, I have no idea whether or not we actually make money on that bottle of fluoxetine. And back in the 90s, we had this conversation back in the 90s. This is not a new concept. So 90s, 2000s, 2010s, it doesn't really matter. We've been having this discussion for a very long period of time. And there was an episode of a show called The West Wing back in the 90s, which I was a teenager in the 90s, so I just now put an age to myself. And there was a guy on this episode who was one of the assistants to the president. The West Wing was all about the president and his aides. His aides being his assistants, like the chief of staff and the communication director and whatnot. And I won't delve into the West Wing because that's not what we're here for. It is one of my favorite shows, but there was a line out of that show, and I'll never forget it. And Josh Lyman, who's one of the assistants to the president, he was the assistant chief of staff, says, yeah, the drug costs 2 cents to make, but the first pill cost $4.5 billion. And part of what has to be addressed in this country is how much it costs us to actually make drugs. It's expensive. It's a very expensive process to go through clinical trials, to go through the FDA approval process, to actually get the drug ready to market, find it in the first place. And there's a lot of trial and failure that's just finding the drug in the first place. So in this system, we have a very expensive research and development cost involved in making drugs. And that's part of the reason why when a drug comes out, it costs so much money. The newer drugs, which are for rarer diseases and are for more targeted populations, are costing 10, 11, 12, 13. I had a claim just a couple of days ago at work, adjudicated through a pharmacy benefit manager for $16,000. And this person is on it all year. $16,000. And if you think about that over the course of 12 months, an insurance company is paying more than most people paid for their houses for a drug. Part of that is mergers and acquisitions. So the healthcare industry is getting smaller and smaller, and that's because the insurance companies are cutting reimbursements. So the healthcare industry at the first line level, meaning your doctor, usually is not an independent practitioner anymore. I can think of very few independent practitioners anymore that actually are in practice for themselves. The number of independent pharmacies is going away. When I started pharmacy 10 years ago in Grand Rapids, Michigan, we had 10 independent pharmacies. That was 10 years ago. Right now, we have 4. So the amount of competition in the retail pharmacy industry is smaller. At the pharmacy benefit manager level, the number of competitors is smaller. And when you look at drug companies are buying up the generic drug companies because that's where all the money is now. So even up at the top, you have Novartis has like 7 generic drug manufacturers, and they're finally starting to roll them back up into one. but you're seeing that as well. But you have to consider that in this country, most of healthcare is for profit, and that profit is not usually generated in the pharmacy. It is in a couple of instances. I'll discuss why that is in a minute. But don't yell at your pharmacist for the price you're paying for prescription drugs. This is above their pay grade. So let's take a look at a few terms. So a few terms you're going to hear me throw out. I'll define these as we go along. Pharmacy benefit manager, maximum allowed cost, average wholesale price, average acquisition cost, wholesale acquisition cost, and no, those two numbers are not one and the same. It may sound like they're one and the same, but average acquisition cost and wholesale acquisition cost are not one and the same number. Dispensing fees, probably one of a couple of numbers in this list that are in the control of the pharmacy in a couple of limited cases. Average manufacturer price, again, that number, no relation to those acquisition cost prices, because usually now we have a wholesaler involved as well. And then there's the usual and customary charge. And usual and customary is one number that the pharmacies can control, and that number will wildly vary from one pharmacy to another. So let's talk about pharmacy benefit managers. Pharmacy benefit managers are third-party companies that are contracted by insurers to manage prescription drug benefits. So if you look at the front of your your insurance card, the company that's processing your prescription drug benefits is not the company that is listed on the claim when I process it in a pharmacy. So you have Blue Cross Blue Shield of Illinois, for example. Your prescription drug benefit manager is not Blue Cross Blue Shield of Illinois, it is Prime Therapeutics. If you have Blue Cross Blue Shield of Michigan, your pharmacy benefit manager is Express Scripts. And if you look on the back of your Blue Cross Blue Shield of Michigan card, you'll see the Express Scripts logo in very teeny tiny type on the bottom right-hand corner of your card. If you have Federal Blue Cross, if you are a federal government employee, you do not have Blue Cross Blue Shield of Rhode Island, who processes those claims major medical-wise. But when it comes to pharmacy benefits, those go through a company called CVS Caremark. Now I believe they call themselves CVS Health, but back in my CVS days, a long time ago in a galaxy far away, CVS and Caremark were just now getting together, and they were just now becoming the behemoth they are as CVS Health now. They dictate the price of the drug, and when I tell you that the pharmacy benefit manager is what really controls the price of prescription drugs in this country, they have the ability to negotiate rebates. Those rebates drive up the cost of the drug for everybody else, because if one pharmacy benefit manager is getting it at a discount, they have to make that money up somewhere else. So somewhere along the line, somebody's paying the bill. And it most assuredly will be you in premiums later. They do not have to disclose their pricing practices in most states. There's a couple of states that have PBM transparency bills, and they really don't even do enough to actually create true transparency. And transparency in this process is a very fluid term. As I talk about these three business models, we're talking about a really fluid term. So spread pricing is what most PBMs use. They basically take whatever they paid the pharmacy and whatever they pay something else, the insurance company or the third-party administrator. Whenever one of those two things occur, there's a spread that's involved. So that may be 10%, 20%, 30% of the cost of the drug, or it may be the difference between average wholesale price, we'll talk about that term in a little bit, and what they paid the pharmacy, which is the discount on average wholesale price. And that number could be 18%. They may give all of the rebates to their third-party administrators or their insurance companies that they represent, or they may only give them half, or they may even only give them 20%. There is no transparency in spread pricing. In the hybrid model, you may get a percentage of the rebates. You may get the claim charge plus a percentage fee as an administrative fee, and they're supposed to disclose this to you. They don't. in most instances. So your third-party administrator in a hybrid PBM model really doesn't know what they're paying for prescription drugs. And even when we get to pass-through, there's still some situations within the pass-through model where there are places where the PBM is charging more for the drug than they should. And in the pass-through model, they're supposed to basically say, whatever we paid the pharmacy, we're charging you for the cost of the drug. We administer your plan on a per member per month basis. So if you have 1,400 members, we'll charge you 1,400 members times $10 a month. That's what your plan charges are from an administrative side for doing our clinical work. They might charge you for a prior authorization. They might charge you for doing prior authorizations or manual claims. They may charge you for processing manual claims. So we'll give you the option of mailing in your claims. And if you choose to do that, then we're going to charge you $350 per claim that we do manually. And they'll usually be fairly upfront with what they're charging you. What they're not upfront about is what they're reimbursing the pharmacy and how they negotiate those contracts, because they're wildly different. So we're going to start getting into some of these reimbursement terms. The first one, dispensing fees. Dispensing fees are fees agreed upon by a pharmacy and a pharmacy benefit manager for the cost to provide pharmacy services. Blue Cross Blue Shield of Michigan pays $1.25 for me to enter the prescription into our database, process the claim, which, by the way, that costs money too. Slap a label on a prescription, count out 30 pills, have my pharmacist verify that I did my job right, have them counsel the patient. All of that we get $1.25 for. Vial, cap, everything, $1.25. That's all you get reimbursed. It does apply even to cash price drugs. So even pharmacies do this within their own cash pricing. There's a dispensing fee that is set into every single one of those prescriptions. And it can be as low as $3.50, might be $12.50. In all reality, it costs us about $13 to $14 to dispense a regular prescription. And so when you go, well, I want the price for a 90-day supply, and then you automatically assume in your head that if you only got a 30-day supply, the price is going to go down by a third. You're wrong. It will not. It's because there's a fixed cost that is built into the price of that prescription. And some pharmacies even have minimum charges for prescriptions. It's not terribly an uncommon practice that says our minimum charge to fill a prescription is $15. So if the drugs cost less than $15, $15 is what we're charging you. CVS back in the day, $9.99 was the minimum cash price. And when I talk about cash, I mean not billed to a third party. So it is a fixed cost that is added to the price of all prescriptions. So whether you get 30 or whether you get 90, that fixed cost is always going to be in that price of that drug. And that's why getting 90-day supplies does save you some money, because you are not paying us that dispensing fee 3 times in a row. Now let's get into how insurances reimburse pharmacies. The first one is maximum allowed cost. Maximum allowed cost in any pharmacy that I've ever worked in is a swear word. Maximum allowed cost applies to generic drugs. And there's supposedly some logic that's built into this, as I've learned from the Pharmacy Benefit Management Institute. So supposedly the logic is they use a reference, and there's a couple of different references they can use to generate this number. One is the National Average Drug Acquisition Cost Database. This is a database I'll talk about in a minute, but NADAC is a federal database that tracks the actual average drug acquisition cost across the country. So if you want to have a rough idea of what your pharmacies are paying on their invoices, you can go out and Google the NADAC pricing database, and that'll be one of your first search results. And you can actually search and see what your drugs are actually costing your pharmacy. And that database is updated every Wednesday. So if you keep thinking that they update that on a daily basis, you're wrong. They update it weekly. It just, with the sheer number of national drug codes we have in this country, it would just be an insane process to do that. regularly. They could go by pharmacy reported acquisition cost, meaning that the pharmacy sent them a copy of their invoice and say, hey, by the way, I'm paying X for a drug. Can you please increase your reimbursement to me? 99.9% of the time, they're going to go, no. And then they're going to use all of that information to generate max on all the other drugs you sent them as well. Because it's just not the one line item on the invoice we're looking at. They will look at all of it because you gave it to them. It can be a manufacturer reported drug price change. And I will tell you right now, insurance companies always respond to the ones going down faster than the ones they respond to going up. Everything in maximum allowed cost is based on a per unit basis, so by the milliliter, by the gram, or by the each. When I talk about each tablet, each patch, each milliliter of an injectable vial, all of those are considered to be eaches. And then a dispensing fee may or may not be added to that price. There are a few contracts I have seen where it's MAC plus 0. To be perfectly honest, it's okay, we'll pay you maximum allowed cost, but we're not paying you for any professional services. So let's apply a MAC price. You have a meloxicam prescription for 90 tablets, and that was paid at a maximum allowed cost of 15 cents a tablet, plus a $1.50 dispensing fee. So how much will your pharmacy be paid? This is a question that shows up frequently on the Pharmacy Technician Certification Board exam. And I can tell you right now, they will give you several ways to screw up your mathematics. So if you multiply that 15 cents wrong, you may come up with a weird number. If you forget to add your dispensing fee in, you may get a weird number. But to calculate this price, you have to first multiply 90 tablets by the MAC price of 15 cents. Now, if you do that, you're going to find out that it's $13.50. So your reimbursement is not going to be $13.50. If you found out that this is $13.50 and you tack on $1.50, you can't possibly get to $14.50. That's not possible. So if we know it's $13.50 and we tack on $1.50 dispensing fee, we're also not going to make it to $16. So your answer is actually C in this particular case. So it is $15. If you got a different number, leave it in the comments. I'd be interested to see what happens on that. Then we have wholesale acquisition cost. This is what drug companies report as their acquisition costs, what they have wholesalers charge pharmacies. In generic drugs, this number is compiled and averaged. And the price is before contracted rebates to buying groups. So when you talk about generic drugs, I have an invoice cost and then I have a rebated cost, because drug wholesalers have to charge everybody the same price, no matter whether or not you're CVS or your Joe Smith's pharmacy on Main Street. Everybody pays the same $3.50. What gets credited back to you later on in life is a rebate, and it depends on how well you're able to negotiate contracted pricing. And that may be anywhere between 10 and 35% of the drug. Or in the case of brand names, it might be 3 or 5% of the acquisition cost of the drug is what you get charged. When it comes to brand name drugs, because there's usually only one manufacturer of a brand name drug, that data becomes wholesale acquisition cost. So let's apply WAC. And we're going to use fluoxetine this time. I'm going to use a 100 count bottle. And I'm going to give you 4 manufacturers. Manufacturer 1 charges $15, manufacturer 2 charges $20, manufacturer 3 charges $10, and manufacturer 4 charges $25. For all the same medication, these 4 drug manufacturers charge those wildly different prices. When I told you there was no transparency in this process, I wasn't making that up. So what you do is you add all of the prices together and then you divide by 4. So what'd you come up with? I'm letting you all do the mathematics real quick. That number is $17.50. So that entire bottle, the wholesale acquisition cost is $17.50. If you went and looked it up in the NADAC database, you probably got a number closer to $4.50, and I'm not making that up. A little bit of a warning. We're about to delve into percentages. So just as a genteel reminder, remember that 1 cent is $0.01, and I always think of percentages in that term. So think of percent as per cent, and notice the space. So 1% equals 1 cent. 1% of $1 equals 1 cent. So if you had $1 and you pulled out a penny, you have $0.01. If that makes sense, great. If that doesn't make sense, I don't have a better way to explain it, unfortunately. So let's talk about average wholesale price. Theoretically speaking, average wholesale price is 120% of the wholesale acquisition cost. A PBM typically will calculate that somewhere between 120 and 125% of wholesale acquisition cost. Again, remember when I said there's no transparency? This is another one of those instances. Back when we were talking about MAC having no transparency, I have seen one drug have 7 different MACs. I actually had one drug. I was looking at claims the other day trying to estimate a copay. I had, out of 141 claims, I had 130 different prices for the same drug, for the same quantity. It was insane. So let's go back to the example of WAC from the previous slide. In that slide, wholesale acquisition cost, as a refresher, was $17.50. So what will happen if the price is 120% of WAC, and what would happen if it's 125? So what you do is, remember, 121%. So we have $1.2 in this case of WAC. So let's take that $17.50, multiply it by 1.2. You come up with $21. Now, if it's 125% of WAC, you get $21.88. And when you're talking about a prescription where you're dispensing it by the millions of tablets or the millions of capsules, that 88 cents is a huge difference in price. So let's go back to fluoxetine, and we're going to apply the 120% model because I like nice even numbers. And we processed a claim for that whole bottle, 100 count, and it paid at AWP minus 10% with a $1 dispensing fee. So what did you get paid? It was $21, right? So if we got paid, if we were AWP were $21, we're going to take 1 minus the percent discount. So in this case, 10%. So 1 minus 10 is 90%. So if we took 90% of $21, I guarantee you're not going to get a whole number. So let's get rid of those two right off the bat. So A and C go bye-bye. Now you're left with something that ends in 90s. Okay, well that's great. If you took out the $1 dispensing fee and committed that math error, that way, D also won't be your answer because $18.90 was this first step. You need to add the dispensing fee in. When you do that, you get $19.90. And again, if you get a different number, leave it in the comments. I'd be interested to see how you got there. Then we have average acquisition cost. Average acquisition cost is a database that is maintained by the Centers for Medicaid and Medicare Services, CMS. That information is obtained in one of two ways. Either the manufacturers will report it, or the pharmacy will send a series of invoices over at CMS's request. They do that once a year. They're called pharmacy invoice audits. They make us send like a month's worth of invoices, and then they use that data to determine the cost of drugs. The database that ends up as a result is called the National Average Drug Acquisition Cost, NADAC database. And in the NADAC database is a wide variety of drugs. If a pharmacy has never sent an invoice indicating a NADAC, or a manufacturer has never sent a drug cost in, you may not actually have a NADAC price for it. I've seen very rare instances of that. There are occasions where there is no NADAC price. This is used then by Medicaid to reimburse pharmacies. So let's take that fluoxetine. The NADAC price was $3.08 for the 100 count bottle. So if you went and looked it up in the NADAC database, that 100 count bottle would show up in the NADAC database as having a NADAC price of $0.0308. So when you look in the NADAC database, you're going to see it in individual pill form. So if you're going to get a 100 count bottle, that price is going to have to be multiplied by 100. And you bill your state Medicaid system for 50 capsules, and they reimburse you NADAC plus $10. So how much money will you get? Well, I guarantee you, since we have a $10 dispensing fee, it is not this one, and it is also not this one. So you're left with $13.08 and $11.04. Well, NADAC for a 100 count bottle is $3.08. Our dispensing fee was $10, so it is not $13.08. In this case, it is $11.04. So your second choice here is going to be the price that you will get. So from Medicaid, you'll get $11.04. So why are prescription drugs still so expensive? Well, that's because only drug manufacturers and pharmacy benefit managers know the price. How many of you are even aware that Lantus costs $504 a box? None of you are. Everyone is oblivious to the price except the drug manufacturers and the pharmacy benefit managers. Even the pharmacist doesn't know what they're getting reimbursed for that drug until that drug actually shows up with a paid claim in the pharmacy. We have these rebate structures. They're also not transparent either. So keep that in mind. And then to control the cost, because these drugs are so expensive, employers now are raising copays higher and higher and higher. And studies show that once you get to about $40 in the cost of a drug, so if your copay is $40 or more, you're less likely to get that prescription. And that number is a very significant number. So if your copay is more than $40 or $50, most of the time you're not going to get it. And I get that. I have seen insurance plans charge as much as $200 for a drug. And that's because the drug's costing them $13,000. They've got to charge you that money or else they're going to get significantly hit in drug costs. And part of the reason I have a job is to contain those costs. So I'm trying to do that, but somebody's got to come up with that money. Now, there are drug coupons that are out there, and in one of these episodes I'll eventually teach you how to do that, but there are so many drug coupons out there that it would be really hard to tell you exactly what each coupon is for. But there are still some drug manufacturers out there that will help you pay the cost of your drugs. And I will tell you this, if you make less than $50,000 a year and you have more than one person in your house, most drug manufacturers will give you that drug for free. Almost always. So it may behoove you to find a pharmacy technician or pharmacist and pay them a few dollars to help you navigate drug discounts. And if they're really good at doing that job, $40 or $50 a month is well worth it when it comes to saving on your prescription drugs. So with that, I want to thank you for joining us today. Leave any questions you have about this episode in the comments. I will be happy to answer them. I answer all questions when it comes to the cost of prescription drugs. I will do my best to answer your question. I don't have all the answers, but I will have some of them. And if you like this episode and you want to see me make more of them, head over to my Patreon page and leave me a donation so that I can continue providing high quality education for you. Thank you so much for joining us.